morning, everyone. My name is Sara Salama. I'm a lecturer of neurology at Alexandria University, and my presentation is going to be about differentiating neuromyelitis optica spectrum disorder from MS. This is my disclosure, and this is my agenda. So I'm going to start by shedding some light on the burden of MS misdiagnosis. As we all know, the diagnosis is not always straightforward because of the heterogeneous clinical and imaging features, the limited specificity of signs, symptoms, MRI, and oligoclonal bands, but we don't have a true incidence and prevalence of such misdiagnoses. Some data is available from case reports and recent publications from specialized MS centers. Around 30% of cases originally referred for MS were finally diagnosed with other diseases. And one study which was conducted in 4 academic MS centers revealed that over 50% of patients carried a misdiagnosis for at least 3 years, 70% received DMTs, and 31% experienced unnecessary morbidity as a direct result. This study was published in 2019 in Frontiers of Neurology. They attempted to suggest solutions to minimize such problem. So these were the recommendation. They recommended that the McDonald's criteria were not developed to differentiate MS from its common mimics, but it was developed to diagnose MS or the high likelihood of disease in patients presenting with typical clinical syndromes. So in the absence of such typical presentation, further clinical and radiological follow-up would be recommended. And also we should not consider any previous events in the absence of objective evidence. And when the clinical and brain MRI evidence are not enough for MS diagnosis, or in patients presenting with progressive course at onset, children or older population, additional workup will be needed, including spinal MRI and CSF examination. Another important point is that we should be able to differentiate and consider alternative diagnoses, which are commonly seen, such as migraine, psychogenic disorders, MRI changes due to vascular diseases, and of course, NMOSD. They suggested some late data which could be of value in supporting or refuting the diagnosis of MS. For example, oligoclonal bands, the presence of Epstein-Barr virus seroprevalence, and the measles, rubella, zoster reaction would favor a diagnosis of MS, while the presence of antibodies for aquaporin 4 and myelin oligodendrocyte glycoprotein would of course favor either NMOSD or MOG antibody disease. This is the 2017 McDonald's criteria. As for the MS mimics, we have a long list of mimics, but we're going to stress on the NMO or NMOSD. The history of NMOSD goes way back to the 1870s, where many cases were reported over the years till 1999, where the first criteria were coined. They were revised in 2006, and in 2015, the international panel criteria were developed, where we rely on them nowadays in our daily practice. Briefly speaking, the pathophysiology of NMO starts in the periphery by unknown trigger, which breaks the tolerance, activate B cells and T cells, and secrete oligoclonal aquaporin 4 antibodies from the plasmablasts, which cross the blood-brain barrier, bind to its specific target antigen on the astrocyte field processes, activate the complement, invite more inflammatory cells, resulting in astrocyte damage and secondary demyelination. Around 30% of cases, they do not have the aquaporin 4 antibody, and 1/3 of those are positive for a different antibody, which is the myelin oligodendrocyte glycoprotein. Usually, they have less frequent relapses and more benign clinical course and tend to present at a younger age of onset. So these are the 2015 criteria. We can diagnose cases with positive aquaporin 4, negative aquaporin 4, or even cases with unknown serostatus, and they stress on the exclusion of alternative diagnoses. Looking at the epidemiological feature, NMO is a female predominant disorder with age of onset ranging between late 20s to late 30s, prevalence and incidence much lower than MS, and pediatric population represents 3 to 5%. It has a unique feature of presenting itself more frequently in the older population, where cancer screening is mandatory because it can present as a paraneoplastic phenomenon. As for the clinical and radiological features, the criteria proposed 6 core criteria, starting with the optic neuritis, which tends to be painful, bilateral, associated with visual field defect, severe with poor recovery, usually involve a long segment of the optic nerve with tendency to involve the posterior structures of the optic pathway, including the chiasm. Here we can see a typical case of longitudinally extensive optic neuritis in a case of aquaporin 4 NMOSD, and here we can appreciate the chiasmal involvement. As for the famous longitudinally extensive transverse myelitis, usually it spans more than 3 vertebral segments, and it's severe in presentation with sphincteric involvement, shows cord expansion and swelling. Pain and paroxysmal tonic spasm are common features. Poor recovery with poor response to steroid treatment. Cervical cord is a favorite location and sometimes extends into the medulla. T1 show hypointensity. T2 shows bright spotty lesions, and sometimes there is ring enhancement. On the other side, 14.5% of cases present with short myelitis, which again tends to be central, involving more than 50% of cord area, and the detection depends on the timing of imaging. Usually it can be detected either early in the disease course or later after treatment or remission. Here we can appreciate the classical longitudinally extensive myelitis with the bright spotty lesion with the same signal as the CSF, and the last image shows the short fragmented myelitis, usually in remission or after treatment. Brain involvement is reported in up to 90% of cases, with the most common pattern of involvement is the non-specific white matter hyperintensities, along with the other 4 clinical criteria: area-bostrema, acute brainstem syndrome, diencephalic syndrome, and symptomatic cerebral syndrome. Area-bostrema is reported in up to 46% of cases, usually presents itself by intractable hiccups, nausea, vomiting, combined or alone, highly responsive to steroid, and it should have very ependymal region of the dorsal brainstem involvement and sometimes even extend to the upper cervical area. Here's the classical dorsal medulla involvement, and here's the extension to the upper cervical cord. The acute brainstem syndrome presented in up to 1/3 of cases. Again, vomiting hiccups are the most common symptoms, cranial nerve abnormalities, and lesions are typically ependymal. Very ependymal, such as these examples, as we can appreciate the very ependymal hyperintensity in the acute brainstem syndrome. The symptomatic narcolepsy or the acute diencephalic syndrome, the diencephalon in general is composed of the thalamus, hypothalamus, ependymal surface of third ventricle, and the periaqueductal area. It presents with narcolepsy, disorder of temperature regulation, appetite change, syndrome of inappropriate ADH secretion, and in some cases, there's altered level of consciousness as a result of thalamic involvement. Here's the typical third ventricular periependymal involvement, and here's the hypothalamic involvement in the case of aquaporin 4 positive NMOSD. The symptomatic cerebral syndrome, which is the last core feature, usually present with encephalopathy, focal neurologic deficits, sometimes can look like breasts or look like ADEM, and usually shows large tumefactive hemispheric lesion with occasional corticospinal tract lesions. In addition to the very common periependymal surface involvement, which is related to the high expression of aquaporin 4, we have corticospinal tract involvement in up to 44% of cases, could be unilateral or bilateral, and it could have the shape of a trident fork appearance. Corpus callosum is one of the favorite sites of NMOSD and is quite distinctive from that of MS. Usually it involves the ependymal surface, tend to take the whole length of the corpus callosum, where it's edematous and heterogeneous, and sometimes show the characteristic famous arch of bridge sign, which imply involvement of the whole thickness of the splenium, such in this case, or the genu of corpus callosum. And here we can appreciate the demyelinating patches involving the body of the corpus callosum. Cortical lesions are rarely noted in the classical NMOSD, may be associated with leptomeningeal enhancement, which by itself is a red flag for MS, can look again like ADEM or BRESS, and recent studies suggest that this is a more typical and more diagnostic feature of MOGAD or MOG antibody disease. Many enhancement patterns have been reported in up to 36% of cases. The famous cloud-like, which is heterogeneous with blurred margins, the periependymal linear or pencil thin enhancement, the leptomeningeal, nodular, and very rarely the ring or open ring enhancement. Here's the cloud-like enhancement and the very pencil thin periependymal enhancement. So to sum up the differential clinical points, the location when central would favor NMOSD as opposed to dorsolateral cord usually involved in MS. The presence of T1 hypointensity and bright spotty lesions would favor a diagnosis of NMOSD. Posterior involvement of the optic nerve or involvement of the chiasm or long segment of optic neuritis would favor NMOSD. And finally, progressive clinical course would suggest a diagnosis of multiple sclerosis. The lab investigations, of course, the aquaporin 4 is one of the most important, and it's usually tested in the blood. Many assays have been reported, but the most sensitive and specific is the cell-based assay. We should be aware of the false positive results with ELISA that can reach up to 1.2%, and also we should be aware of the false negative results, which are detected more frequently during remission, after plasma exchange, or after use of immunosuppressive drugs. Some cases we might need the CSF analysis, which differ between remission and relapse, and is more pronounced in acute myelitis relapses. The white count could be elevated, but it's more towards neutrophil and eosinophils rather than the lymphocytes detected in the CSF of MS patients. Elevated protein level. Oligoclonal bands can be detected in 1/4 of cases, and aquaporin 4 in the CSF can improve detection in negative cases. And also the glial fibrillary acidic protein and interleukin 6 level are very much elevated in NMOSD rather than in MS. This is the summary of the lab differential points between NMOSD and MS. So we have a very long list of red flags against NMOSD, but I'm going to stress on 2 important points. First, the progressive overall clinical course would usually point away from a diagnosis of neuromyelitis optica, and the presentation in older population should raise the question of cancer screening, especially lymphoma or paraneoplastic phenomena. This is the last part of my presentation. It's going to be about MOGAD or MOG antibody disease, which we can see is an overlapping diagnosis. It overlaps between optic neuritis, myelitis, ADEM, aquaporin 4 negative NMOSD, and even encephalitis. Usually it presents itself at a younger age at onset, usually early 20s, maybe even younger, shows less female to male predominant as opposed to NMOSD, and more frequent in the Caucasian population. The clinical presentation, according to this study and many other subsequent studies, the most common presentation is unilateral optic neuritis, followed by bilateral optic neuritis, then ADEM, then longitudinally extensive myelitis, and the least frequent are simultaneous optic neuritis and transverse myelitis and short-term myelitis. Interestingly, 25 to 32% of patients in 2 series fulfilled the 2015 criteria for NMOSD, and 15 to 33 fulfilled the revised McDonald's criteria for MS, and this only adds more confusion to the distinction between the 3 entities. The MOGAD optic neuritis, usually bilateral, severe in presentation, but tends to be more anteriorly located, with good prognosis and recovery, and usually the MRI would show swelling and enhancement of the perioptic tissue. Here's the characteristic perioptic swelling and hyperintensity. The transverse myelitis, again, longitudinally extensive, centrally located with associated swelling, but the lower thoracic and the conus area are more frequent parts of involvement rather than the cervical cord in the NMOSD. And there is disproportionate sphincteric and erectile dysfunction with good motor recovery. ADEM is a typical presentation, especially in young population, and it can even present itself in adults as well. And the persistence of MOG antibodies in ADEM patients would predict future relapses. Usually, MOG ADEM tend to have higher CSF cell count and more widespread changes on brain MRI. And sometimes they might resemble leukodystrophy. And residual cognitive problems and poor concentration have been reported in some cases. So this is a case of 6-year-old female patient presenting with MOG antibody disease. The first attack was an attack of ADEM, as we can appreciate the cortical, subcortical lesion with the characteristic enhancement. And the second attack was again ADEM, as we can appreciate the leukodystrophic pattern on the axial scan. Cortical encephalitis, again, is a common presentation, and usually it presents with seizure. This study was published in 2018. They coined criteria for MOG encephalomyelitis. The criteria were the monophasic or relapsing acute optic neuritis, myelitis, brainstem encephalitis or encephalitis, or any combination of these syndromes, along with MRI or electrophysiological evidence compatible with CNS demyelination, and finally, and most importantly, the seropositivity for MOG IgG using cell-based assay and full-length human MOG as a target antigen. Brainstem lesions can present isolated or combined. Usually they're fluffy and confluent, and area between them has been reported as well. But generally speaking, brain lesions are very difficult to distinguish between the classical NMOSD and MOG antibody disease. The disease course is relapsing in up to 80% of patients, and half of those patients would relapse in the first few months after onset. Loss of seropositivity is associated with a monophasic disease course, and the risk of relapse is thought to be lower in patients treated with prednisolone for at least 3 to 6 months, as compared to patients treated with only shorter duration of time. The lab finding, the MOG testing is performed in serum using cell-based assay, and the CSF analysis is variable, could be normal, could be inflammatory, but the predominant cell is usually lymphocytes, such as MS, but different from the classical NMOSD. We can have elevated protein or elevated protein with no cells, and again, oligoclonal bands can be detected in up to 15% of cases. And in contrast to the seropositive NMOSD, aquaporin-4 NMOSD, the coexisting serum antibodies are rare in MOGAD, where it presents in only 9% of cases, as opposed to 1/3 of patients with aquaporin-positive NMOSD. The double positive entity is extremely rare, and there is overlap between those two entities. That's why we should be aware of the false positive results, and we should rely on the clinical and imaging data that should be compatible before considering the diagnosis. And this slide shows the overlap between seronegative NMOSD and MOG. And this diagram will show the different patterns of involvement in the 3 disease entities. Just sum up what we have already discussed. So the take-home message, aquaporin-4 and MOG testing are indicated when suggestive clinical and radiological features are present, and in cases atypical of MS. Cell-based assay is the recommended method of testing. When antibody testing is negative in highly suggestive cases, we should consider repeated testing during relapse and before treatment, or even CSF testing. And when the diagnosis is not confirmed, we should consider acute treatment and follow up clinically and radiologically to avoid any misdiagnosis. Thank you so much.